everybody, and welcome to today's webinar titled Cholangiocarcinoma in Focus from Research to Live Experience. My name is Nikola Mihinec. I work as a medical and scientific project officer at Digestive Cancers Europe. And it's a real pleasure to welcome all of you today on behalf of DICE and all our partners. Today's webinar, we're going to bring together science, lived experience, and advocacy, which is exactly where some meaningful progress happens. For those who don't know, cholangiocarcinoma is a rare but devastating cancer that forms in the bile ducts. It's unfortunately often diagnosed quite late with limited awareness and significant unmet needs. This is why today's goal of the webinar is going to be quite simple. We're going to look where we stand today, where we are, and where we should head in the future when we talk about cholangiocarcinoma, of course. And before we start, I would like to also mention some housekeeping rules. That this is going to be 1 hour virtual event. We'll have a presentation from each speaker, and at the end of when the speakers finish, we're going to have session for questions, Q&A, questions and answers. So I would like to encourage all the participants today that if they have some questions or some thoughts arise, that they post them on the Q&A chat, and we will address them a little bit later. Also, this webinar is recorded, so you're also aware of that. And we're going to jump also to our first speaker of the day. It's a real pleasure to introduce Professor Jesus Maria Banales. He's a professor of molecular biology and head of the liver disease group at the Bio-Guipuzcoa Health Research Institute in San Sebastian, Spain. He's one of the leading experts in Europe when it comes to cholangiocarcinoma research, with extensive work spanning from epidemiology, from disease mechanisms, biomarkers, and emerging targeted therapies. Professor Banales, together with our third final speaker, Helen Moorman, they published the Cholangiocarcinoma 2026 research paper. I'm also going to link it in the chat so you can all have an overview as well. And in his presentation today, Professor Banales, he's going to guide us through the current scientific understanding of cholangiocarcinoma, which will include some risk factors, treatment standards, and future challenges. Professor Banales, the floor is yours.
Thank you very much, Nicola. Good morning, everyone. It is a great pleasure for me to participate in this webinar, particularly in the February Awareness Month for this cancer. And as Nicola mentioned, I will provide a general overview on this malignancy, focusing on research developments, clinical advancements, standard of care, and ongoing challenges. These are my conflicts of interest. I have organized the presentation in 4 chapters, let's say, or aspects. First, I will provide a general overview on this cancer, providing then information on the natural course, treatments, and personalized targeted therapies. And finally, we will discuss a little bit on next clinical challenges. So cholangiocarcinoma includes a heterogeneous group of malignancies characterized by the expression of markers of biliary differentiation. Usually they arise as a result of the malignant transformation of cholangiocytes, which are the cells of the bile ducts. It is the second most common primary liver cancer after hepatocellular carcinoma, and its incidence is increasing worldwide, being particularly high in certain Eastern countries such as Thailand, China, or South Korea, with more than 6 cases per 100,000 inhabitants. Traditionally, it has been considered that cholangiocarcinoma represents between 10 and 15% of all primary liver cancers, 3% of all gastrointestinal malignancies, and to be responsible of about 2% of all cancer-related deaths. However, these data are clearly underestimated due to errors in diagnosis, coding, and data retrieval, particularly during the last years. This is a very new slide on mortality, age-standardized mortality rate in 2021 in 52 countries of Europe, America, Asia, and Oceania, according to data from the World Health Organization. As you can see here, the mortality rate of cholangiocarcinoma, here in black in each country, is in general below 5 cases per 100,000 inhabitants in the different countries, but with significant differences from one country to another. It is particularly higher in certain Eastern countries, such as Korea, Japan, or Hong Kong, or Thailand, because the incidence in those regions is higher, and lower in other countries, for example, in America and also in certain countries of Europe. You can see here in parentheses the percentage of change of mortality associated to cholangiocarcinoma within the period 2011-2021. And you can see in red the countries who experienced an increase within these periods in the mortality rate of cholangiocarcinoma, and in blue those countries that experience a decrease in terms of mortality. You can see that most of the countries experience an increased mortality rate within this period. Among the potential causes of this could be an increased awareness and knowledge on this cancer during the last years, a better diagnosis, and also an increase in incidence. It is important to highlight that in most of the cases the etiology is unclear or unknown. However, there are several factors that highly increase the risk of cholangiocarcinoma development, like the presence of cholecalciferous gallstones, cirrhosis, chronic biliary diseases like Caroli or primary sclerosing cholangitis, hepatitis B or C viral infection, and certain liver flukes, like Orpistorchis riverrini and Clonorchis sinensis, which are two parasites endemic in certain regions of Southeast Asia and responsible, at least in part, of the high incidence of this cancer in those regions. On the other hand, there are other factors that induce moderate risk but that are highly prevalent, like alcoholic liver disease, type 2 diabetes, tobacco use, or MASLD, a metabolic dysfunction-associated steatotic liver disease. Aging is another important risk factor. The median age at diagnosis, according to data from the International Biliary Tract Cancer Registry, was 66 years, and 75% of the patients presented more than 58 years at diagnosis. And last but not least, there is a proportion of cases, around 5%, that present germline mutations in different tumor suppressor genes that increase the risk for the development of different types of cancers, including cholangiocarcinoma. Regarding the natural cause, according to the potential differences in etiology, pathogenesis, risk factors, incidence, and prognosis, and with the support of the AMMF and also the NSCA, the coding of cholangiocarcinoma has changed. The WHO has recently approved a new classification in 2022 of these cancers based on their anatomical origin, now being classified in intrahepatic, perihilar, which are the most frequent one, and distal cholangiocarcinomas. Based on this, we aim to evaluate the natural course of cholangiocarcinoma in centers from Europe, and particularly to identify the similarities and differences between these three new coding subtypes. The NSCA registry, or the registry of the European Network for the Study of Cholangiocarcinoma, is a multi-center observational study, and for this particular analysis, we included cholangiocarcinoma cases confirmed by histology or highly suspicious by cytology, cases diagnosed between 2010 and 2019. From more than 3,000 cases included in the registry at that time, we evaluated more than 2,000 for the epidemiological analysis and almost 2,000 for the survival analysis, evaluating all cases together and also comparing the three subtypes. This is a very collaborative study involving 26 referential centers in Europe from 11 countries. So this slide shows the clinical management and survival according to the different treatment. Patients just receiving best supportive care experience a dismal prognosis with a median overall survival of just 4 months. That increased up to 10.6 months in patients receiving active palliative treatment, mainly the combination of gemcitabine and cisplatin. Regarding surgery, patients following surgery are those with the best prognosis. When the surgery is completed, the median overall survival was 45 months. Then we identify several clinical and demographic variables associated with prognosis in a univariable analysis. Then we carry out a multivariable analysis and show that there are 3 variables independently associated with prognosis. As expected, the ECOG performance status and the disease stage, but also the levels of the cancer biomarker CA19-9 in serum. Also, we evaluate the involvement of the success of the surgery and the presence or absence of lymph node invasion. And as expected, patients with complete tumor resection in the absence of lymph node invasions are those with the highest median overall survival, 52 months compared to the other groups. Next, we analyze the clinical management and survival, comparing the three subtypes of cholangiocarcinoma: intrahepatic, perihilar, and distal tumors. No difference were found in terms of response to surgery or to active palliative treatment. However, we found that patients with intrahepatic cholangiocarcinoma under best supportive care show worse overall survival compared to perihilar and distal tumors, probably to the fact that a proportion of patients with intrahepatic cholangiocarcinoma presented chronic liver disease and cirrhosis. We carry out the same study, more or less, in this case, in centers from Latin America. We observe more or less the same results with differences in the prevalence of certain risk factors. But intriguingly, we found significant ethnic disparities in terms of tumor presentation and outcomes. So we compare individuals Caucasian, African, and Hispanic. And in general, we found that Caucasians show the best outcomes with cholangiocarcinoma, whereas patients from African ancestry or Hispanics show worse survival, particularly because patients usually were diagnosed in a more advanced stage, and more frequently they were not treated with systemic chemotherapy. So there are important awareness and policy changes required, particularly in those regions. Regarding the treatments and the personalized targeted therapies, systemic therapies for patients with cholangiocarcinoma has experienced a significant transformation during the last years. In 2010, the ABC-02 trial showed that the combination of gemcitabine and cisplatin showed a modest but significant benefit in terms of overall survival and became the standard of care for patients with advanced cholangiocarcinoma. Since then, different treatments or triple combination with gemcis has been investigated, but with not additive benefit. But since 2019, different clinical trials have shown significant benefit in patients following surgery, in first line combining chemotherapy and immunotherapy, also targeted therapies after progression in first line. So this is the BILCA phase 3 clinical trial that showed that patients undergoing surgery who received afterwards capecitabine show better overall survival compared to an observational arm without receiving any treatment after surgery, from 36 months in the observational group compared to 51 months in the group treated with capecitabine. Based on this data, capecitabine is the standard adjuvant treatment for all cholangiocarcinoma cases. This is the ABC-02 trial that I showed you previously, published in 2010, a phase 3 trial that combined gemcitabine and cisplatin compared with another arm just with gemcitabine alone. And as you can see, there was a slight but a modest but significant benefit for the combination of gemcitabine and cisplatin in terms of progression-free survival and also median overall survival, becoming in 2010 the standard of care for patients with advanced cholangiocarcinoma. So very recently, in 2022 and 2023, a combination of this chemotherapy in this regard with immunocheckpoint inhibitors, durvalumab or pembrolizumab, was investigated, and both clinical combination of chemotherapy increase the overall survival of the patients compared to chemotherapy alone, becoming the first-line treatment for patients with advanced cholangiocarcinoma since that time. It is important to highlight that cholangiocarcinomas are highly heterogeneous at the mutational level. This is a limitation in order to find common and effective therapies for all cases, but this is a unique opportunity for personalized targeted therapies. In this regard, around 40-50% of genetic alterations are druggable, and different targeted therapies have already been approved in second line in patients with advanced cholangiocarcinoma who progress to the first line with gemcitabine and cisplatin. So it's very important to perform the molecular profiling of the tumor at diagnosis in order to try to identify any of these actionable alterations and be eligible for further targeted therapies. Some of these genetic alterations are more frequently found in intrahepatic tumors like IDH1 mutations or FGFR receptor 2 fusions, where there are other genetic alterations more frequently found in perihilar and distal tumors, like, for example, HER2 amplification, BRAF mutation, or KRAS mutations. Here I show you different targeted therapies, different clinical trials in phase 2. In second line with drugs specifically targeting FGF receptor 2 fusions, IDH mutation, BRAF mutation, NTRK fusion, and HER2 amplification. As you can see, all of them show a significant proportion of patients experience an stabilization of the disease, a partial response, or even a complete response. And all of them are already approved in second line in patients with cholangiocarcinoma. For those patients who do not present any actionable alteration in the tumor, this is the ABC06 trial, a phase 3 clinical trial that show a modest but significant increase in overall survival in patients receiving FOLFOX compared with an observational group. And this is now recommended in second line for patients not harboring any actionable alteration. Regarding liver transplantation, this is a retrospective study where patients were transplanted for descompensated cirrhosis. There in the liver explant, they found cholangiocarcinoma lesions, and they found that when these lesions are smaller than 2 centimeters, these patients presented higher survival and less disease recurrent post-transplantation compared to patients with a more advanced cholangiocarcinoma, indicating that patients with cirrhosis and intrahepatic cholangiocarcinoma in very early stages could be good candidates for liver transplantation. Similarly, here at the Mayo Clinic, they also investigated perihilar resectable cases, smaller or similar to 3 centimeters. In general, they found a good, survival post-transplant around 70%, particularly high in patients with primary sclerosing cholangitis, and a recurrence around 30%, significantly lower again in patients with PSC. So transplantation is now a standard of care for cholangiocarcinoma, and there are prospective studies now ongoing, and we will revise the data soon. Regarding next clinical challenges, well, we are experiencing a very good momentum for cholangiocarcinoma in terms of research and new treatments. And now there are a big range of therapeutic strategies being investigated. So there are new chemotherapies that are being evaluated in experimental models and in patients with cholangiocarcinomas, as well as different biological treatments and cellular therapy. For example, there are B-specific antibodies being investigated in order to activate the immune system, to attract the immune system into the cancer cells. Also CAR T cells against specific tumor antigens, combination of immunotherapies and different chemotherapies, combination of different immunotherapies, as well as radiation, tumor ablation, and different treatments targeting, for example, vascular receptors and different tyrosine kinase receptors. Another field of research of intense investigation is also the therapeutic vaccines, which basically is to identify tumor neoantigens, present them to the immune system, to the dendritic cells, and then inject the dendritic cells into the human body in order to activate the immune system against the tumor. And in this kind of rare malignancies is key the international collaboration, and a clear example is this one, the International Cholangiocarcinoma Registry, which is now being cholangiocarcinoma biliary tract cancer registry, because not only include cholangiocarcinoma cases, and also we are including gallbladder cancer and ampullary tumors. So with the effort of too many groups and centers, we were able to recruit more than 6,000 patients from 54 international institutions and 21 different countries. Multiple studies have been already published, and ongoing studies are ongoing right now. An important collaboration milestone is the publication very recently in the last weeks of the third cholangiocarcinoma consensus, in this case 2026, status quo, unmet needs and priorities, published in Nature Reviews, Gastroenterology and Hepatology, where 147 international experts from 35 countries participated, including scientists, clinicians, and patients associations like AMMF, and where we describe a little bit the current knowledge of the disease, as well as the recommendation and key research priorities. So I recommend to anyone interested in this topic to read this important manuscript. So in conclusion, cholangiocarcinoma research is evolving fast, and this is providing tremendous hope for patients and for the community. These are highly heterogeneous tumors, but they show a unique molecular profile, particularly for personalized treatment. So there is very heterogeneous molecular profiling, but there are high chances to potentially identify actionable alteration. That's why it's very important to conduct a molecular profiling in tumor tissue, a diagnosis in order to potentially identify these genetic alterations. Patients should be managed by multidisciplinary tumor boards, and new targeted therapies are coming soon. I want to thank the different institutions that support our studies, as well as my research team in San Sebastian and all of our national and international collaborators, and all of you for your attention. Thank you very much.
Thank you very much, Professor Banales, for your insights and overview of the latest scientific developments in the cholangiocarcinoma world. I mean, definitely you show that science is developing in a positive direction, but there's still a lot of challenges still remaining. For example, when it comes to early diagnosis and maybe access to innovation. And science innovation, however, only truly matter if they are translated into the better outcomes and experiences for people living with the disease. And that's why at the DICE we always try to promote patient perspectives because we believe that perspective is not optional, but it's essential. And therefore, I'm very pleased to introduce our next speaker, Rohini Singh Sisodia. She's a lawyer by profession and a certified health and well-being coach. She's a yoga teacher and also, most importantly, patient advocate. She will share her lived experience. She's going to highlight patient priorities, unmet needs, and what truly matters and what makes a difference during and beyond the diagnosis. So, Rohini, thank you for being with us today, and over to you.
Can you hear me well, Nicola?
We hear you well. Please go ahead.
Okay, thank you. So thank you for that amazing introduction. So as you've already introduced to me, I am a health and wellness coach, but today I'm here really somebody who's lived the experience of cholangiocarcinoma, and I'm here to bring in the patient voice into the space of science, policy, and care. Why patient perspective really matters is because not only that we've heard, that cholangiocarcinoma is rare, complex, it's aggressive, mostly comes with delayed diagnosis and limited options, and often full of uncertainty. But clinical outcomes do not fully capture the lived experience because beyond scans and treatments, what patients really experience is stress, fear, anxiety, uncertainty, trauma, identity loss, major disruptions to family, work, daily life, and the struggle to keep going. So the patient lived experience and perspective does help healthcare system to see the full human reality, to be able to provide support at all stages. And so my intention here is to bring that live patient experience into cholangiocarcinoma conversation, and also discuss actually the areas of advocacy's priorities and gaps in order to inform research and policy and integrative care with human story behind the diagnosis. So just briefly, I was born with a colorectal cyst and had colodocoduodenostomy at the age of 1. I was diagnosed with poorly differentiated distal cholangiocarcinoma at 35, almost after 34 years, and underwent Whipple surgery and received chemo and immunotherapy. Today, for more than 4.5 years, I'm in complete metabolic remission. But what I want to share is everything that happened around those clinical words, and share my journey from being a caregiver to being a patient to thriving, not just surviving. So my journey actually with cancer began in 2018 as a caregiver to my brother. He was diagnosed with rare and aggressive sarcoma, giant cell tumor. We lost him within a year of diagnosis at age 27. And we tried almost everything that we could to save him, but we couldn't. And that left us, a family of 3, my parents and I, quite in grief and lost. And back then I was working as a lawyer in India, and after a difficult few years, I had just moved to Belgium in 2020 for love, as my husband is Belgian. And in the hope of starting fresh, we had, begun to rebuild a new life. I was pregnant in 2020, hopeful, dreaming again of family, of stability, of a thriving personal and professional future. And the pregnancy, of course, brought a lot of light and joy back into our lives and into my family lives. And then one night in March of 2021, everything changed overnight. I was in my last trimester of pregnancy. I developed sudden pain, rushed to the hospital. It was cholangitis, an infection. They scheduled me for ERCP. But before that, I lost my child in utero. We named him Victor. And it was really, I cannot explain what it was to give birth to a stillborn baby and getting to hold him only for a few hours. A part of me actually shattered that way, that in a way that I cannot describe. And yes, I was grieving deeply, but also facing a lot of medical uncertainty as no clear answers were immediately available for what had happened. So they found stones in my gallbladder. They scheduled me for a gallbladder surgery. But we were, my husband and I, we weren't convinced, and we felt that there was something more here. And we did need a specialist care. So we moved our hospital and moved to a university hospital. And that decision changed everything for us because they performed scans again, ERCP again, and they found that the diagnosis of cholangiocarcinoma. It started with a confusion between adenocarcinoma or cholangio, and ultimately after the surgery, cholangiocarcinoma. Again, hearing the word cancer, again, having lost my brother to it, was devastating because all those memories of fear and pain surfaced again for me. So diagnosis did come with confusion, with shock, and a sense of that everything that we had been working towards had, all our dreams and all our plans had collapsed overnight because I had just moved countries. I left my job. I was navigating transition. There was, loss and isolation because of COVID, and now this. So, it was very hard for us to accept what had hit us. And we had no time to digest it all because very quickly I was scheduled for a Whipple surgery, which I had in 2021 May. And then because the surgery was not clear resection, R1, that changed my further protocol, and I had chemotherapy, immunotherapy. But the adjuvant treatment again came with its own uncertainty because the opinions were divided between 3 different specialists in 3 different hospitals. But we decided to take an approach which included everything, chemotherapy and immunotherapy together. The treatment did come with a lot of side effects and complications, including, hospitalization due to severe infection and interruption of therapy, because there came a point in time when I had to stop chemotherapy and immunotherapy continued as a monotherapy. However, for many months, images after the surgery also kept showing metastatic lesions in kidney, liver, certain other spots. And although the initial staging, it started before the surgery to be stage 2, moved into stage 3 because of resection and massive lymphatic involvement. It became stage 4 with the lesions. And of course, living in this space of uncertainty around the prognosis and the treatment, waiting between scan, is the hardest part of the journey. And with no family history of cancer, with my brother with me, these sudden events were particularly confusing for me and my family. And of course, there was a lot of physical pain, but it was nothing compared to the grief in my heart. I was desperate to make it for my family because I felt like they cannot have this same story again as my brother. We had already lost so much, so I held on to that, and that became my reason for living to start with, until I realized I really wanted to live for myself. And that's when I really understood very early in my healing journey that I had to do something more alongside treatment for my overall well-being. And I decided to make certain radical changes, lifestyle changes, and did many, many other things that empowered me. So I am now over 4.5 years here with NED since 2023, and what began as a fight for survival became a deeply transformational healing journey and gave me a purpose, and I would like to highlight more on that later. From a medical standpoint, molecular profiling played a very important role in my treatment because my tumor was MSI high, which helped guide therapeutic decisions, particularly use of immunotherapy. Immunotherapy wasn't recognized and not reimbursed in the cholangiocarcinoma cases in Belgium. So my case was, considered for direct compassionate use. And even though the opinions were divided amongst hospitals, we are very glad that we chose an option that involved immunotherapy. So just talking about, what the life is after Whipple surgery and the challenges that a patient faces after treatment, which we call survivorship, But for many patients, it does not feel like return to normal. My body is permanently changed. I continue to live with ongoing symptoms, regular monitoring. And after Whipple surgery, I experienced a major lack of guidance on managing long-term symptoms, digestion changes. They are deeply individual. Malabsorption can lead to exhaustion, fatigue, muscle loss, malnourishment, and for finding what I could eat, right enzymes, supplements. It required a lot of trial, a lot of personal research. And even after the cancer was gone, I faced chronic pain, landing me in emergency care with no medical cause. And finally, we could start addressing all the other issues that I was facing now that the cancer was gone. So this also made me realize that how important the structured survivorship care is. And I tried very hard to connect with other Whipple surgery patients at younger age, but I couldn't find too many. And it's not easy for a patient to do this alone. So we do need more awareness and better pathways of care after treatment. What really helped me actually alongside medical care, because I was really fortunate. I had an excellent medical care and a team of highly competent doctors who in many cases went beyond their way to support me. Also because I was a young patient, and I remain, deeply grateful to my doctors and my oncology team. I would say excellent medical care truly saved my life. But at the same time, I would not be showing up to life today the way I do, despite everything that happened, without addressing all dimensions of healing. And that is the difference between being cured and truly being healed. And this journey has taught me that treating the disease is not the same as supporting the person living with it, and both are essential. And that is why I truly believe that approach to any illness and cancer has to be holistic, because as I mentioned earlier, there's so much happening on the side, and with rare cancers and cancers like cholangiocarcinoma, there's often no standard protocol. I know the situation is improving tremendously and there's a lot more clarity since 2020. But there were opinions which were divided. The timelines are uncertain. We are living scan to scan. Requires a lot of mental strength, and that comes from emotional and psychological support. Also, the integrative care, it really helped me cope with the grief, fear, uncertainty, and supported very practical needs and addressed challenges like nutrition after Whipple, what I could eat, fatigue, pain, exhaustion, quality of life related challenges that I was facing. So I want to stress here that even WHO defines health not as absence of disease, but as a complete well-being. So we are talking about physical, mental, emotional, social. So addressing all these aspects together is what helped me feel healed again. And from a patient perspective, I feel integrative support is not optional, it's essential. It empowers patients, improves coping and resilience, supports adherence to treatment, enhances quality of life, and addresses long-term survivorship needs. So just to talk about how my work started, it was an idea, RSS Heal was an idea born in the hospital, because when I started feeling better and I spent a lot of time, 2 years in the hospital, I began sharing what I was doing, and I felt even better. So that's when purpose found me, through connection with others who were going through their own journey. and to be able to empower others in their journey to health and healing, because I really felt that there was a strong need to bridge this gap between conventional care and overall well-being through coaching, advocacy, workshop across cancer care continuum, starting from prevention, risk reduction to supporting during the treatment and going on to survivorship. So it wasn't really an easy part to leave everything that I had known, because I had no idea as a lawyer about this world. So I unlearned and relearned and went back to school and educated myself, trained myself. But that's what makes my life really meaningful and purposeful. So I want to say here that my journey hasn't been just about surviving. It's about remembering life's deeper meaning through pain, finding purpose in pain. And it was about knowing that there is a person beyond cancer who wants to live life to the fullest every day and support others in doing so, despite the treatment, despite diagnosis, despite illness, no matter what. So quickly, I want to highlight here also, I know there'll be a lot talked about what are the advocacy priorities, but from a patient perspective, I want to say that yes, we do need more awareness that saves lives, but also early life biliary diseases like neonatal cyst in my case deserves long-term follow-up, because in my case, nobody told me that it could have those implications, and we didn't even consider it as a follow-up. Again, molecular profiling can meaningfully guide treatment decision. So that has to be brought in if it's possible right at the right stage as well. And it can address the uncertainty. Pregnancy-related presentations are rare, but more attention is needed, because again, that could have a different outcome. Survivorship care, I've already talked a lot about, the integrative care, the whole person care, and what it could do if we begin early care and extend beyond cancer control to include pain management, nutrition, fertility consideration, returning to work, transition, and long-term quality of life. So a concrete action that I keep thinking about, various ideas, but I feel that we need to bring in, integrating lifestyle and supportive care clinics with the patient support organization within hospitals alongside advocacy, coaching, mentorship, because it can improve the quality of life and various other challenges that the patient navigates, physical, emotional, practical challenges of long-term survivorship. And again, patient perspective is especially critical in rare cancers where data is limited, and collaboration, meaningful collaboration, can address the uncertainties around diagnosis, treatment protocol, impact overall outcome, and take care of patient care dynamics, leading to a more patient-centered progress. And with the rising cancer cases, I just want to say it is time to move from discussion to action. So to close, cancer did change my life in many ways that I'd never imagined, but it did not end it. And I stand here in many, many roles as a patient advocate, as a wellness coach, empowering others through the whole person cancer care. But to anyone who's in the midst of the situation, I want to say that it might feel very hard and difficult at the moment, but your future can look very, very different from today. This is just one chapter of your life. Healing happens one day at a time. So if my story can give one person hope or make even one person feel seen or heard, then it's all worth it. So thank you for listening. Thank you for involving me and including patient voice. And thank you for all the work that everybody does here. Through my work, I remain committed to supporting patients in a holistic way. But I truly believe that together we can build more compassionate, patient-centered system of care. Thank you.
Thank you so much, Rohini, for this powerful message and for sharing your story with us and your perspective as well. Your contribution to this webinar, I mean, what more can I say? Thank you for everything presenting today. And you brought together also, you brought and put a face on statistics as well, because usually in the healthcare world and medicine world, patients often come out just as numbers. So, but we have to be aware that behind every number, there's a person, there's a family, and there is also, most importantly, human life, which is profoundly affected by this cancer. And as you said, and in fact, it is time to take action. It's time to act now as well. That's why we have to turn these lived human experiences also into systematic changes, which in fact requires strong advocacy, strong data, and strong collaboration with all the policymakers and stakeholders involved. And therefore, I would like to welcome also our next speaker, Helen Mormon. She's a founder and the CEO of AMMF, the Cholangiocarcinoma charity. Helen has been the forefront of cholangiocarcinoma advocacy for more than 2 decades. She led landmark initiatives, and she just pushed the policy engagement across the UK and Europe. And today she will speak also on advocacy developments and how data has reshaped the narrative around cholangiocarcinoma, and also what lies ahead. So, Helen, thank you for being here, and over to you.
Well, thank you very much for that introduction. And I have to say to Rohini, what a powerful message of hope. And that's so important to all our cholangiocarcinoma patients. So thank you for your courage in sharing that this morning. But thank you very much to the organisers for giving me the opportunity to speak today, especially during Cholangiocarcinoma Awareness Month, really important. What I'd like to do is to tell you a little bit about AMMF, the Cholangiocarcinoma charity, and our work. And as Nicola said, I am Helen Morment. I'm the CEO at AMMF. So back in 2002, at its inception, AMMF was the world's first charity dedicated solely to cholangiocarcinoma. And today, 24 years later, we remain the UK's only cholangiocarcinoma charity. We work nationally, across Europe, and collaborate globally. We're particularly delighted now to see a growing number of cholangiocarcinoma advocacy groups building across Europe, and I'm going to come back to those this morning. Now, before I talk about AMMF's work, I'm just going to briefly review what cholangiocarcinoma is, and I know that Jesus explained it brilliantly this morning. So cholangiocarcinoma is a primary liver cancer. It's also known as bile duct cancer, and it's one of the biliary tract cancers, and the others are gallbladder cancer and ampullary cancer. But it is important to know that there are 3 anatomical variations of cholangiocarcinoma. The distinct subtypes are intrahepatic, and that's when the cancer happens inside the ducts in the liver. The hilar or perihilar, that's when it happens at the join of the main ducts as they come together, leaving the liver and become the common bile duct, which goes down to the intestines. And actually, despite the statistics, which are skewed by coding and so on, again, which Jesus has alluded to this morning, perihilar cholangiocarcinoma is believed by many to be the most commonly occurring type. And then we also have extrahepatic or distal cholangiocarcinoma, and that's when the cancer happens anywhere along that common bile duct from the cystic duct down. So back in 2002, we began with 3 simple aims: to raise the awareness of cholangiocarcinoma, to provide information and support, and to encourage and fund research. Those aims remain exactly the same today, and I'm going to expand a little on each of them as I go through my talk this morning. And to understand where AMMF is today, I'm going to explain where we began. So over the years, we perceived one of our major problems to be the lack of robust data to support our requests for better recognition of this challenging cancer and for policy improvements. It seemed that a key barrier to improvements in the cholangiocarcinoma landscape was the lack of robust data to back up the lived experiences we were witnessing: rising incidence, significant variation in diagnosis and treatment, and early diagnosis and survival rates are not improving. In fact, they're considerably worse than for other cancers. And also, very worryingly, and contrary to the existing data at that time, we're seeing more younger people being diagnosed and losing their lives. So that's why, back in 2018, AMMF commissioned and funded a first-of-its-kind cholangiocarcinoma data project from within Public Health England and later with Health Data Insight, in collaboration with partners at Imperial College London. Data from some 50,000 patients with biliary tract cancers between 2001 and 2018 were used. And these findings confirmed what we knew. Incidence is increasing year on year. Cholangiocarcinoma is a growing, untargeted problem. More younger people are being affected. Over 20% of patients were under 65 years old when diagnosed. Survival rate is appalling. Mortality is parallel to incidence. And some very concerning facts were uncovered that we weren't aware of, including many cholangiocarcinoma patients receive none of the treatments currently available for this cancer. No surgery, no stenting, no chemotherapy. And there's geographical variation in routes to diagnosis and treatment, and also in incidence. This substantial body of work has resulted in 3 papers, all now published. So we finally have the robust published data to support what we have been seeing. And backed by the findings of our data project, AMMF went on to launch the Rethink Liver Cancer campaign. But why rethink liver cancer? Well, our work then showed that the incidence of cholangiocarcinoma was almost equal to that of hepatocellular carcinoma, also a primary liver cancer, but the one that is most commonly referred to as liver cancer. And again, more recently, from the National Disease Registry Service, the data has again confirmed this. With the 2022 incidence of hepatocellular carcinoma at 3,175 and cholangiocarcinoma at 2,973. However, we can also see that the incidence of cholangiocarcinoma is increasing at a faster rate than hepatocellular carcinoma year on year. 35% for cholangiocarcinoma and 21% for hepatocellular carcinoma. And so in the foreseeable future, the incidence of cholangiocarcinoma will overtake that of hepatocellular carcinoma. So we're asking, why is it that cholangiocarcinoma is so under-recognized? The time has come to rethink liver cancer. Stop thinking of liver cancer as only hepatocellular carcinoma, but to fully recognize cholangiocarcinoma as a primary liver cancer too. To raise public and professional awareness of cholangiocarcinoma regionally and nationally, and particularly within the planning of health policy, we also produced a white paper, which we launched at AMMF's very first Westminster reception, the heart of the UK government, in February 2024. However, it's really hard to change long-held perceptions, and we've continued to push the Rethink Liver Cancer campaign further, with another Westminster reception in February 2025. And we also took the campaign to Holyrood, the heart of the Scottish government, in June that year, where we asked for better care and support for those with cholangiocarcinoma in Scotland, where our new Scottish data was showing pro rata the incidence is as high there, if not higher, than in England. We will return to Westminster this Cholangiocarcinoma Awareness Month, once again to ask those with the power to make policy change for better recognition of cholangiocarcinoma and far better care for all those diagnosed with this most challenging of cancers. And our theme this year will be shaping the future from early detection to improved survival. But the patient is at the heart of everything we do. So in parallel with our awareness raising and policy work is our second aim, providing information and support to those who need it. And we do that in a number of ways, but most importantly, with our comprehensive website, a one-stop shop for everything to do with cholangiocarcinoma. And for those in Europe, we have a website in 8 different languages. And this is really important help for those with cholangiocarcinoma across Europe. We're daily users of all the social media channels, where we also have private discussion groups. These are extremely well used and offer great support to those in the UK, across Europe, and in fact, globally. We have a growing number of resources, all available to download from our website or as hard copy, and we're currently supplying these to our growing network of nurses too for their cholangiocarcinoma patients. And working with the Precision BTC network in Europe, many of the treatment information booklets and sheets we now have available are in a number of different languages, which can be accessed via AMMF's website. And as Jesus mentioned this morning, we're learning more about the mutations and gene alterations in cholangiocarcinoma. And with a growing number of therapies now available to target these, molecular profiling is of increasing importance. And we have an informative booklet and a video which explains all this in an easy to understand way. AMMF is pleased to have been involved with the Sapphire ABC10 trial from the very beginning, and latterly with others in Europe as the trial took shape. There's a pressing need for new treatment avenues, and Sapphire ABC10, with collaboration between the UK, France, and Belgium, provides this. An international multi-centre trial, it combines 2 of the most important recent advances for cholangiocarcinoma: the addition of immunotherapy in the first line and targeted therapies. We believe it is in recruiting very well, and we're all hopeful of a very positive outcome. And because it's important for all those with cholangiocarcinoma to have access to clinical trials information, AMMF has a website area listing those trials currently open and recruiting. And we also provide a link on the page to clinical trials available across Europe. As I mentioned at the very beginning, we're absolutely delighted to see the growing number of cholangiocarcinoma advocacy groups across Europe. We have ATUVIBI in Spain, APIC in Italy, and the newest group of all in France. And early in 2025, 3 groups, AMMF, ATUVIBI, and APIC, collaborated to produce a comment article, which was published in The Lancet on World Cholangiocarcinoma Day 2025. This article gave us the opportunity to describe the current situation for people diagnosed with cholangiocarcinoma in Europe, including the dismal 5-year survival rate, geographic disparities, and the need to shorten approval times for innovative new treatments. And the European groups have gone on learning from each other. In December 2025, hosted by APIC, the European groups and AMMF met in Venice, wonderful location, to discuss where we are, the difficulties we face, and how we can help each other We all plan to meet again in May this year at AMMF's Cholangio Conference in the UK. So back to AMMF and its aims. Our third aim is to encourage and support research. This is an area where we've seen some amazing changes. Over 20 years ago, when we began, there was little or no interest in cholangiocarcinoma. We had to search for anyone doing any research. And now the number and quality of funding applications coming to us is astounding. And we have and are supporting research across the UK and internationally. But the work at AMMF goes on. Since those early days, we have come a long way in that we now have the cold, hard data, that robust data we've long needed. But the widely held perception of cholangiocarcinoma being a cancer of low incidence continues. And with it, the lack of awareness, which leads to many people not getting the care they should have. So we continue our work towards changing and improving what is happening, including with our Rethink Liver Cancer campaign and working towards creating centres of expertise. We will continue to push for recognition and improvement until each cholangiocarcinoma patient can be confident that their treatment pathway is correct and they are receiving the best possible advice and care. And I'm just going to leave you with a reminder of AMMF's annual 3-day European conference. This will be live in the UK, 13th to 15th of May, and then available on demand. Registration details can be found on AMMF's website, and as always, there is no fee to come to our conference. Thank you.
Thank you very much, Helen, for showing us how evidence, advocacy, and collaboration, in fact, does drive real change. And thank you for reminding us how far the community has come and how much the advocacy groups such as AMMF, ATU-VB, and APIC do actually make significant change in the world of cholangiocarcinoma. We have now also reached to the end of the presentations from our speakers and towards the end of the webinar. So we addressed research and clinical innovation, lived experience and patient priorities, and how advocacy is also shaping policy and systems. And with final minutes remaining of the webinar, I would like to pass on to a Q&A session. As I see, we already have some questions in the chat. Some have been answered already. Which also leaves us with a final question. This one from Pete. He says, "Thank you, Rohini, for an excellent presentation. I have just been diagnosed with incurable cholangiocarcinoma and start immunochemotherapy next week. I can only agree that the medical cure is not the same as healing." Statement from Pete. Thank you very much, Pete. Rohini, would you like to give some words on that?
Thank you. Yes, I did respond to him, and I want to send you best wishes for your healing and recovery. But to answer your question, I feel integrative care also has to be personalized based on your unique situation. I wish I could say there's just one thing, but there is no one thing. It is small steps and just introducing lifestyle changes, starting from diet, nutrition to movement, physical activity to managing stress, emotional and mental, seeking emotional and mental support. And again, it is a personalized approach. Thank you.
Thank you, Rohini, for your words. Would you like to, Helen, I saw some recently question arising, but you also answered with to Juliana. But do you want to maybe answer it also here?
Yes.
So the question is, how can we better align research priorities with what patients tell us they actually need? Very interesting question, I think.
It is.
I think also Rohini could also add up on that afterwards.
Yeah, I mean, it would be difficult. I could sit here all morning to answer that question. So I have suggested that they email me and then we will do our best to collaborate and see what we can do. But a really good question.
Thank you. Anybody would like to add something on that?
Yeah, I mean, again, as Helen said, there's so many things that we could say, and I did put that in my slide as well to, from patients need, support all across the cancer continuum from, we talk about prevention, but also during treatment and after. So, yeah, there's a lot of things that need to be taken care of. At the same time, I'm also I'm just saying that can also be reached out to Pete if necessary. He can always reach out to me, and I'm happy to support in any way that I can. Yeah.
Thank you, Rohini. Thank you, Helen, as well. Professor Van Alice, would you like to maybe address some of the questions you already answered live in the chat, as we have another minute or two to do so?
Yeah, thank you. Thank you very much. Yeah, I mean, some of the questions were based, for example, on the early detection of cholangiocarcinoma. This is an important unmet need. We face different problems. The disease is very heterogeneous. There are some patients, with chronic liver disease that develop cancer. Some of these chronic liver diseases are induced high risk, where other induced moderate risk. But most of the cases are sporadic. They are developed in a theoretical normal liver. So I think we need to try to see the potential value of screening policies for the early detection, particularly in individuals at high risk, and to investigate on more accurate diagnostic tools, particularly for the small lesions. No, we have conducted a large international study comparing cholangiocarcinomas from in patients with chronic liver disease or without chronic liver disease. And interestingly, data from the international registry have shown that cholangiocarcinomas in the background of chronic liver disease are being diagnosed earlier in an earlier stage tumors, and this impact in survival because they are more eligible to cancer, and they respond similarly to systemic therapies compared to cholangiocarcinomas sporadic. So that means that surveillance probably matters, and we need to, standardize, investigate in prospective trials, different surveillance strategies in high-risk individuals, patients with primary sclerosing cholangitis, with cirrhosis, with other diseases, and see the benefit. And again, support studies on liquid biopsy, on biomarkers that can help in the early detection. No, but I think this is something important because early detection is key in order to increase survival in patients. No?
Can I just jump in there very quickly to agree strongly with Jesus? We do need better diagnostic tools, but we need them to be available earlier in the patient's journey. I can't think of another word. Many times we hear from our patients, they go to their primary care practitioner, to their GP, again and again with these vague symptoms they know are not right for them, but the GP doesn't think might be cholangiocarcinoma. If we had liquid biopsies that could be done easily, blood tests could be done easily, or what we are now seeing, and we're very interested in this here at AMF, is breath tests. You breathe into, was like a where you're checked to see if you're not too drunk to drive. Is very similar to that. It's very simple. And it can be done very early. And as Jesus says, if we catch these people early, it's a whole different story. And that's what we need to do. Much better diagnostic tools that can be used much earlier.
Definitely, and I couldn't agree more with both of you, Khaled and Jesus. Thank you very much for your answers, and I would like to thank all of the speakers and all of the participants who are here today with us for the openness, expertise, and also your commitment. And I think one thing that was very clear that to make progress in cholangiocarcinoma, we need to align research, advocacy, and also patient perspective and move them all together in the same direction. So thank you very much to everybody who participated with us today. And I would just like to also mention some events which are upcoming for Digestive Cancer Europe, which is European Colorectal Cancer Awareness Month. We're going to have an event at the European Parliament on 26th of February. We have Lunch and Learn on March 10th with the topic How Movement Supports Health, Prevention and Recovery. And also we are organizing a fun run on the 3rd of July in Munich as a part of DICE's 11th masterclass, which is held in parallel with ESMO GI. So thank you very much to everybody for today's participation, and wish you a great rest of the day. Thank you very much.
Thank you.
Thank you very much. Goodbye.